Thanks, Nick. Just to check, first of all, that you can hear me before I start talking. Can you hear me?
Yes, all good.
Brilliant. So thanks to you, thanks to Debs and the team for inviting us to speak about remote monitoring and how we're using it in patients with inherited cardiac conditions. I am going to speak to long QT syndrome, where we are using remote monitoring to improve patient experience and create additional capacity in our overstretched outpatient clinic services. And then I'll hand over to Ed, who's going to speak about hypertrophic cardiomyopathy, where we're using the Ortus platform slightly differently in patients who are starting a new medication for HCM with outflow tract obstruction that requires intensive monitoring and lots of symptoms assessments. So, just to set the scene, first of all, for anyone unfamiliar with inherited cardiac disease, and to try and explain why we have capacity challenges. I mean, I think there are capacity challenges everywhere, but in particular for patients with inherited conditions, they require lifelong care. And that means regular clinical review, regular risk assessments, touch points for education and support, and genetic testing. But because this is inherited disease, it's often not just the patient we need to think about, it's also their family. We screen their family members clinically and or with genetic assessment where possible. And with most of the conditions that we're thinking about, there's a 50% risk that first degree relatives will be affected. As a result, and so the combination of the fact that this is lifelong disease, probands are not discharged, and that the fact that screening generates these new referrals, we see growth in our services over time. And this is some data from King's College Hospital, where I'm also involved in the ICC service, which has just shown how year on year we see the number of patients that require our care and input increasing. And obviously that brings with it many challenges. The appointments traditionally for these patients have been at least annual, and that's based on consensus statements with rare disease and in rare conditions like inherited cardiac disease. It's, you know, consensus statements that guide our care, but it's also historically been part of hospital appointment booking systems where it's been difficult to book a patient beyond a year without losing them to follow up. However, most of the people we see are low risk, they're asymptomatic. And that annual face-to-face review that particularly we were tied into pre-COVID is less desirable for those who live a long way away from us. Many do, because we're a tertiary centre. Patients are travelling long distances with the logistics that entails. And many of our patients are young. They've got busy jobs, they've got young families, and taking time away from those is more challenging when you feel well and not in need of seeing a doctor. So is there anything in addition to offering virtual appointments, which have certainly helped in this space post-pandemic, but is there more we can do to see these patients in a different way, helping them and helping us? So this is where remote monitoring has been something we explored. We came across the Ortus platform during the cardiac surgical waiting list prioritization piece that Debs has already talked to. And what we set out to do was look to see how we might use PIFU, so that's patient-initiated follow-up with remote monitoring pathways, extending that follow-up interval from annually to greater time intervals, but bringing in annual notes review. The Ortus platform lends itself very nicely to that. It allows us to send out annual symptoms assessment questionnaires. It allows us to assess our patients' mental well-being, which can be a significant problem for young people with inherited cardiac conditions, which bring with them, in some instances, risks of sudden death. It allows us to push out education, push out lifestyle advice, send resources to our patients, including some videos that we recorded to help them. What we have worked with the team, the Ortus team, to do was to integrate ECG downloads within the platform. We use the CardioMobile 6-lead devices, which have been validated and shown to be effective and useful for measuring the QT interval and to give accurate QT measurements, which of course is important if you're not going to see a patient frequently, that there's still an opportunity to gather data on how they are doing in a way that encompasses more than just a symptoms assessment. And for long QT syndrome, the QT interval measurement is important. So this is our pathway. There's a lot written on this slide, and I don't want you to even try to read it all. I'm going to walk you through the key points. Our service is led by one of our clinical nurse specialists. We identify patients with long QT syndrome who are importantly low risk and asymptomatic. We onboard them onto the platform face-to-face in the clinic, which we've found is helpful in this patient group. There are obviously different ways of onboarding patients, and that is not the only way to do it. But we onboard them onto the platform, we give them a CardioMobile device, and then simultaneously put them onto the PIFU pathway within our own local electronic patient record. We are then able to annually push out symptoms questionnaires, mental wellbeing questionnaires, invite the patient to download their ECG, which comes to us through the Ortus platform. We're able to push out the reminders about lifestyle advice, which is really important actually in this patient group, where there are certain things like avoiding medications and being cautious around tummy bugs, being cautious with competitive exercise, that are important in addition to medication to keep these patients safe. Importantly, we do need to make sure the data that we collect and the assessments that we make through the platform integrate with our electronic patient record, the local one, and that does require a data upload. We can use postal Holter monitors if required, if the patients have symptoms. And at the moment, we're offering the next face-to-face review after 3 years rather than after 1 year, although we hope to push that further to 5 years, to be honest, with this patient group. Of course, if patients become more symptomatic or if their ECGs show any problems, then we want to see those patients and escalate them back into the clinic setting, which we are also able to do and to accommodate. So the purpose for this was to try and make things better for patients and also better for the service. We've talked about how the patient experience when you're low risk, you're asymptomatic, traveling long distance is not always ideal. This allows patients to reduce their face-to-face visits. It allows them to send us ECG information from the comfort of their own homes, reducing time off work, reducing travel costs. But it's good for the service too. As we said, the service growth is inevitable, and demand outweighs capacity in our ICC clinics. This means that we are offering fewer face-to-face appointments to patients who are low risk and asymptomatic, and therefore creating additional capacity for those who are high risk or those who have symptoms, and making use of PIFU. The diagnostic side, we were struggling to accommodate Holter monitors because of difficulties with demand outweighing capacity. For patients coming in person, this was also not ideal. If you're traveling long distance for an appointment and then traveling back the following day to return a 24-hour Holter recording, that was really very undesirable. And this pathway also makes use of postal Holters, which mean fewer trips for the patients to the department, and increased capacity for Holters within the department to be used in other spaces. In terms of what we've learned, these are early learnings from a reasonably new pathway. The staffing is, of course, important. Cross-cover of that back end is necessary to make sure that the patients are, their data is monitored, so that escalation can be made if appropriate at any point. Clear ECG traces can take a bit of practice working with the patient, and we now ask our patients to make additional downloads in the first few weeks of going onto the platform to make sure they have that memory for a year down the line. We need to make sure we have notes review slots built into our electronic health record booking system so that the care is joined up between the platforms. We're careful about avoiding digital exclusion and discussing with each patient alternatives. And we continue to monitor the progress within a group. I'm now going to stop talking and hand over to Ed, who's going to talk a little bit about hypertrophic cardiomyopathy. Thank you.